Morning, Quentin.
Hi, good morning. How are you?
Good. Nice to meet you.
Nice to meet you too.
Morning, Jennifer. Morning, Thomas.
Good morning. Nicole was planning to join too, so she's
Oh, okay, like in her
tied up.
office, right?
Yeah, she's probably just tied up here.
Okay. She's joining in her office, or will she be joining you in yours?
Oh no, in her own office.
Oh, okay. Okay. And I see Rose has accepted as well. Is Rachel joining us as well?
Rachel doesn't start till next week, so
Oh, okay.
Yeah.
Right. Okay. Well, we'll send out a summary of what we talked about today.
Okay.
I think we're just left waiting for, oh, there, Nicole. There's Nicole. Perfect. Hi, Nicole.
Hi, yeah, I'm here.
Okay, great. I think that's everybody. Chrissy's gonna join us when she can, and so will Christine. Nikki, I'm not sure if she was free. I think she had another conflicting meeting, but I think she'll just join us when she can. So I'll just get started then. I'm just gonna share my screen here. Can everyone see my screen okay? I can't see the chat or anyone. Okay, perfect. I'll just have to rely on people telling me through audio. So this meeting today is just going to be recorded and transcribed. So yeah, thank you everyone for joining today. Today we're going to kick off the NSPH Cerner Build Cycle 3 for Anal Dysplasia Clinic. Oh, am I lagging here? Oh, there you go. Before we start, I'd like to start off this presentation by acknowledging that the land that I'm presenting on today is the traditional territories of the First Peoples of the Hunkaminam language, whose historical relationship with the land continues today. As a settler and an uninvited guest on this land, I acknowledge that I am privileged to use and share this land and will continue to commit providing culturally safe care to First Nations, Inuit, and Métis people in BC. Just as introductions, my name is Vanessa. If we've never met before. I'm one of the clinical informatics specialists. Again, I'm not sure if Christy's on the call yet, but she's also one of the clinical informatics specialists with us, as well as Christy Manzano, which some of you may know as the surgery sustainment CIS. I also have Mike on the call here as one of the CIMs, as well as Jesse. Nikki Ordano can't join us today, but she is the transition project manager for anal dysplasia clinic in this cycle. In the call, I also have HIM and RDS members, Jennifer from the ambulatory team, as well as Cynthia from scheduling. Quentin's joining us from HIM data quality as the Reg BA. As for our SMEs, we have Thomas, Nicole is our CNL, Rose, who's currently our lead OPD clerk, and Rachel, who is going to be the oncoming clerk, fulfilling in for Rose. So today for our agenda, we'll just go over the current state, as well as the medical service that's happening in current state. Then we'll go over kind of core location build, some scheduling items, and then we'll transition to the ambulatory items. And then if we have time today, we could just go over some of the miscellaneous stuff that we can validate, here if we have time, or just over an email is fine too. So to start with the current state, I think previously the Jeanette, who was the previous PCM, decided that anal dysplasia wouldn't be built out as a full clinic, and anal dysplasia would just be placed under OPD, where they're scheduled as minor surgery procedures. Anal dysplasia does have a core location built out in Cerner, but it's actually not active. And the screenshot was kindly provided to me by Jennifer. So as for the medical service mapping, prior to Cerner, it looks like anal dysplasia used general surgery as a defaulted medical service for scheduling minor procedures. And then this kind of continued after our go live. It was recommended that the medical service should reflect the specialty of the provider performing the procedure, but there's not really like a general practitioner medical service available with the pre-minor surgery or minor surgery encounter types. So I think after a discussion with Jeanette, it was just confirmed that the reporting should be driven by the surgical procedure in the MPL, and adding additional medical services could kind of impact that data quality. So currently, I believe anal dysplasia clinic is just using general surgery, but the patients in this clinic should probably be registered to family practice. And this was recommended and confirmed during a NSPH base build session. So I just wanted to confirm with the group today, because this never got coded, or this, never got code value grouped. I'm just wondering if there's like a list of other medical service you guys would prefer, or would you just prefer to have it just family practice? Oh, I can't see the chat if anyone's saying anything.
I'm not really sure if we can use anything other than family practice.
It sounds like you could also use general surgery, like we could add family practice and general surgery, but just to confirm, have you guys been using family practice or have you guys been using general surgery?
Family practice.
Oh, okay. Okay, so then we'll just
But
have
then
them.
that, like in our documentation, I'm putting in family practice, but for the booking, is that coming under like general surgery then? Yeah.
Yeah, for booking under general surgery.
I see.
So one of the things that is confusing, I don't know if it makes a difference, but then even for the documentation, like the doctors are saying it is confusing because the only things that come up are general surgery type stuff, and it's hard for them to find their own documentation sometimes.
I see. So would the preference just be for family practice if you guys had a choice rather than having both options?
What do you think, Rose?
I think it would be best just we use the same thing for the booking as well as on the doctor side. Like if we agree to change a general practitioner, the booking, the medical service maybe will be the same. I think that would be the best. Otherwise, it continues confusing.
Just to check the results on that if it's like, yeah.
Sorry, there's just a bit of background noise, Rose. So just to reiterate, would it be less confusing if you just use family practice then? So it's the same across the board?
Yes.
Okay. Okay, so I can note that down, and then if something else comes up, we can revisit that. So as for our current state, my understanding of the referrals is that so for external referrals, most of the external referrals come from family doctors via fax, which will land in the work queue monitor, and then the referral encounter is created. The referral is then moved to the work list for triage by Dr. Jonathan Grennan, and then the clerk will call the patient to book the initial visit. And as for the initial visit and day of procedure, my understanding is that providers are completing a pre-procedure consult in their private office, and then they're completing a consult documentation that's on a physical paper form that I'll share in this next slide. And then the slates are submitted to the OPD clerical staff via WorkQM. And then the appointments are created in Cerner using surgical scheduling, which leverages the MPL. And then on the day of procedure, the patients will present to OPD, where the clerk will flip their encounter to minor procedure. And then the patients will get their procedure done. And then the documentation by nurses are completed using the peri-op doc. And then providers are using a mix of like a procedure note in PowerChart as well as the form here. And currently, I believe there's 4 providers performing these minor procedures in SPR. So this is the form where the providers are also filling in. I just wanted to confirm with the team, is this right?
Yes.
Okay, perfect.
So this one is usually like they kind of work through it at the appointment. Like I'm not aware of any consult notes prior.
Okay.
But this is what they like once they first see the patient. When they come here, this is what they fill out for each visit.
Okay. Yeah, I couldn't find any detail on what they were using prior to consult, but it must be like in their private practice, like probably another application. But yeah, to my knowledge, they're filling this out during their visit. Is that right?
Yes.
Okay. As for follow-up, my understanding is they're indicating the follow-up timing on that same sheet, and then the clerks will manually book based off that date. Is that right?
Yes.
Okay. And then Rose had told me that you guys also have like a separate Word document to track, I guess, provider availability as well.
Yes, there's a spreadsheet to record the follow-up request here, because when they give this document back to me,
Yeah.
doesn't mean I have time or I have enough spot to book all of them. So
I see.
I have to keep them on the spreadsheet to keep the tracking.
I see. So you're tracking on the spreadsheet in
Correct.
case you don't have time in the moment to schedule it in Chatbook.
Yes, but also
Okay.
sometimes the follow-up won't be until 1 year or 2 years in advance, and we don't have the schedule for the year after that. So I
I
cannot.
see.
Yeah.
Okay. So there is that component where we're doing off of Cerner. Okay. So as for scheduling, the AD clinic doesn't have its own clinic book and shop book. They are scheduling under OPD minor book. And again, we just talked about that document where they're keeping track of provider availability if the appointment is very far in advance. So just as a summary, there's no core location or clinic built that's currently active for anal dysplasia. We don't have a medical service mapped yet. We don't actually have an internal referral order or a follow-up order. All the scheduling is done under OPD minor book, which you guys share the AM OPD future request list with other clinics within OPD. So we'll just talk about the core location build now. This is just a quick summary of where AD will be. I'm sure you guys know that it's here. And then you guys will share the reception here. The purple squares I've identified are just some of the printers, but we could talk about that later. So should anal dysplasia have its own core location? We'll kind of go over two options. So our first option is whether or not we should turn on the core location that is already built. Yeah, we wouldn't need additional build for that. We would just activate that. And activating that would allow us to create a proper clinic book as well for AD. You can also have specific request lists for AD, and that would be a bit cleaner to help create new referrals and follow-up orders as well. You can route these like new internal referral orders and follow-up orders and just have like a separate dedicated request list. Patients can be properly registered under family practice instead of general surgery. Not that you can't do that now as well, but it would just be more distinguishable. And you could still use surgical scheduling, which you guys leverage the MPL for. As for the cons, I think we'd have to redesign the workflow a little bit because you'd have a new referral order workflow, new follow-up processes, perhaps a new scheduling structure. We'll just have to make sure the reporting integrity is not compromised, and there will be cutover that needs to be done. I'm just going to stop here. Are there any comments or questions?
Now, other than that, I just think that this would be really helpful. One for scheduling, it will be really helpful, and also for well, the whole workflow really. And we also have the remote waiting system that will be starting this summer, so then this would, I think, help in that aspect as well.
Perfect. And then as for option 2, anal dysplasia will remain under the OPD core location. So some of the pros to that is there's no risk to the current reporting and data quality. Everything will be the same. Again, reporting will just be driven by the surgical procedure, not based off of the medical service. There would be no minimal build effort really, and it just maintains your current existing scheduling structure, and there wouldn't be really any disruptions to your current workflow. However, some of the cons that we thought of would be you would continue to have that kind of overloaded OPD request list. My understanding, it is quite burdensome for the clerks to just be going through that future request list and sifting out the specific anal dysplasia referrals that get mixed up with, I guess, plastic clinic referrals as well. And sometimes if you guys are getting very high volumes, it could be risky where you guys miss some of these appointments. Another con is, and I just have to confirm, I guess you wouldn't you wouldn't use surgical scheduling anymore. And I guess there'd be no ability for you guys to build these specific anal dysplasia referral orders and follow-up orders.
Vanessa, I'm so sorry. I had my hand raised, but I've realized you can't see it. Regarding that, using the existing, because right now they're using a surgical minor procedure appointment type.
Yeah.
And I apologize that we didn't discuss this first, but going back to your last slide where you said they would use the referral orders, they would use the follow-up order, but they would keep their surgical scheduling appointment type. Is that correct? Can they still keep their surgical scheduling appointment type and still have follow-up orders? Because I'm not aware of that workflow, so maybe we could talk through that. I think for ambulatory, they would use new appointment types, and therefore that's why there would be cut over.
Oh, okay. Okay.
And maybe and not be able to use the master procedure list. That's the surgical scheduling part.
Yeah, I see.
And then in the next slide, I think because you had that they would keep their surgical scheduling workflow. Of course, no follow-up order, no referral orders, that kind of thing.
Sorry, so maybe I'm confusing myself. So I guess they wouldn't be able to do surgical scheduling
Right,
in this
if they
aspect.
use
I
the
see, because it's
ambulatory
ambulatory.
one.
Sorry,
Right.
maybe I must have confused them.
And so is that master procedure list for you guys, is that an important piece of what you do? Is that a concern if you don't have that?
What does it mean then for like the documentation?
Yes,
Because
good
it's
question. So
still-
there's a few things. Like if with the surgical scheduling, the primary reasons you'd want to utilize surgical scheduling, there's kind of three reasons. So one is if the procedure requires any sort of anesthesia, like from an anesthesiologist, for example, because you need surgical scheduling to create an anesthetic case for the record. So that's one reason to use surgical scheduling. Another is the use of peri-op doc, and that's something that the OR nurses only are able to use. So if that's something that you guys need to use, then you require surgical scheduling. And then the third thing is SPR, like from the Ministry of Health. If there are procedures that need to be reported on to the Ministry of Health, then surgical scheduling is required because there are some specific fields only available with like surgical appointment types that SPR takes that data for. And so basically, if any of those three things apply to your procedures, then we kind of need to use surgical scheduling. But if they don't, it's almost better not to utilize surgical scheduling because it does necessitate some more like steps for the clerk. It's a bit more complicated. There's more work involved per booking. So that's kind of I don't know, like, does that apply to you guys? Any of those three things are those requirements or?
Well, for right now, we use the peri-op doc, but we're not giving any anesthetics. Like the providers are giving local anesthetic only, but not like any sedatives or anything like that.
I see. And then do you know about the SPR portion, like reporting to SPR? Because there are certain procedures where the Ministry of Health essentially requires, like they want the information about it. So that's also like a bit of a deal breaker. Like if SPR does capture like data from your procedures currently, that might be something we would need to preserve.
So I'm not entirely sure because like right now, like the AD is done in our minor surgery room, which is separate from the actual surgical procedure rooms here. So I don't know what that does.
So none of it's actually performed in SPR. It's just done in your minor procedures room.
Yes.
Mm.
And just, I know it's very confusing, but there's the SPR room, but then when I say SPR, I mean the Ministry of Health Surgical Patient Registry, which is a different thing. It's very confusing with these acronyms.
From my understanding, because of the nature of it being minor procedure, it does not go to the surgical patient registry.
Correct. And so that's a good point. So are these all minor procedures? If they are, then yes, we don't have to worry about I should just say surgical patient registry to reduce confusion. But yeah, we don't have to worry about that if they're all minor procedures. So it essentially comes back to peri-op doc in that case. If you want to continue using peri-op doc, you will need to use surgical scheduling. But if you don't think there's a requirement to use peri-op doc, then technically you could just revert to the more default ambulatory way of scheduling, kind of what's showing on here, like just with, the normal referral order, the follow-up. And it's a bit simpler in terms of the clerical steps to schedule them. But again, I'm not sure if maybe there's value in you guys using peri-op doc because it does capture some additional data that can't really be captured elsewhere, like in iView, for example.
I mean, the aspects of the peri-op doc would mostly be if you had a procedure where, the patient was under like a sedating anesthetic, and you would clock in and clock out like your case times, who was in it, what items were used and stuff, right? And when I think of peri-op doc as well, in like the recovery sense, it would really just be like when the patient would come into phase one, leave phase one, and then come into phase two and leave phase two. But if they're not even going through SPR, I don't think, I mean, it just sounds like to me they're not really deal breakers for you guys if you don't document on peri-op doc anymore. Is that correct?
Doesn't, but yeah, I mean, but then that leads to the question for all of our other minor surgeries that we do here. We only use peri-op doc. That's all we've ever used.
Yeah, and that's the thing. Like, if that has been working for you, like, it's probably good not to change it, Like, if that's the established workflow and you're not having issues, the data's good. Another thing with peri-op doc is it's very good if there's ever any implants, just because that's like something that you can document easily with peri-op doc. Again, usually with minor procedures, probably that's not a thing, but yeah, I think it's just good to think about this type of thing. But like, if what you're saying is peri-op doc is established, you use it for your minor procedures, it might be simpler to just utilize that. Yeah, you know what I mean? Because it sounds like you already have clerks that are doing surgical scheduling, correct, for these minor procedures? Yeah.
Yeah.
Could we still not leverage surgical scheduling if AD had its own core location?
Oh, no, we could. It's almost a
Oh.
separate question. So, I mean, it sounds like, I guess I'm curious what you guys think, like Thomas and Nicole, about this core location question. Like, would you prefer having a dedicated core location for the anal dysplasia clinic?
I think it would be a lot easier, especially for our scheduling too.
Mhm.
I'm just curious about the cutover requirements since I was just was on a back-to-back meeting just with Doug, Lisa, and Ron about OR cutover, and there is going to be quite a lot of activity there. So from this perspective, wondering what are some of the cutover pieces that are required.
So I'll jump in for the scheduling piece. Of course, you can use a new location, it would fall under surgery if you're going to still use the minor surgery. So then what you're doing is right now you're under SPH, OPD minor something like that procedures. So now all of those appointments need to go to their new location. They'll all have to be rescheduled. You can't exactly use the reschedule function, but they just need to be scheduled under the new location. And so therefore that's kind of the cutover piece. Same patients probably can use same encounter, just need to in Chatbook move those patients into the new appointment location. So that part of it is a cutover piece.
And just to expand on that,
scheduling.
I think also if you are using a new core location, you might actually need to update the encounters as well, because they need to have that new location. Although the thing is, based on how New St. Paul's is working, I think you might have to do cutover anyways, because even if you did not utilize a separate new core location, I believe that like the OPD thing is going to be changing anyways for the new site. So I don't know. But anyway, Kirsty, I see your hand is up. You probably know more about that.
Sorry, I just had a question actually about the SPH OPD minor procedure peri-op tracking, and if we had a separate call location, if these cases could still be pulled into that. I don't know if we know or if we need to speak to surgery. Because current state, these minor procedures that are done for AD show on your peri-op tracking. Is that correct, Nicole? So would you still want to see these?
Sorry, yes. We would still want to see them.
So Jesse, I don't know if you know or if we're best speaking to surgery.
Yeah, it's a good point for sure, and I think it's something we'd probably want to just get a for sure answer from surgery. I believe, based on when I used to be on the surgery team and do some build, that you can like link multiple core locations to one peri-op tracking shell. But I think it's definitely good for us. Wazi would know for sure. So yeah, I think we should maybe just double check with surgery about that.
Thank you.
So sorry, Vanessa. Yep, go ahead.
Sorry. So if it's under family practice, then would that affect our ability to see it on the peri-op tracking page?
No, that would have no impact.
Okay.
Yeah.
Okay.
That's just for the encounter.
Yeah, that's just medical service. It doesn't that won't mess anything up, thankfully.
So hearing all of this, I'm hearing that we are leaning towards perhaps having our own core location, given a few things we kind of have to follow up on.
Yeah, and I was going to say, I think this slide needs to be redone because I think
Confusing,
because it's not. So it was almost like, are we moving to an ambulatory? I felt like this slide was more like, are we moving to an ambulatory? But the location can be utilized by surgical scheduling, so that's like a separate thing, as was mentioned. And then also, are you moving to the referral orders and more of an ambulatory, which would be under SHAP book and a different build for scheduling. That's kind of a separate thought.
Okay.
Yeah, because based on this discussion, it sounds like we probably would not do that, and we would just kind of preserve the way that you guys are currently doing the workflow. It's just you'd have a new core location with the caveat that we can make sure that those cases booked under your new core location will still appear on that same peri-op tracking board.
Yeah, that sounds good.
Okay, I'll fix these. It was quite confusing for myself having to distinguish some of these things too. Okay, are we okay to just move on then? I'm just looking at time. I just want to leave some time for, I'm assuming there are head nods. And then we'll just talk about the scheduling piece. I know there was a request to add all of these specific clinic books and appointments. I kind of just wanted to quickly go over it. Is this still the same? Like, are you guys still wanting these things? If this is the case, like we would have its own. It would still be under the OPD bookshelf, but then you would have your own book.
It's look good to me.
Okay. Sounds good.
Vanessa's are also on Tuesday. We have a nurse practitioner.
Oh, yes.
Alisa Mosh is going to join us. So the Tuesday no longer only Dr. Brennan.
Okay.
It will be Brennan or Alisa Moore.
Okay, the NP, right? I can connect with you, Rose, just to double check her times. Okay. Perfect. I was just gonna hand this over to ambulatory if they wanted to speak more about the ambulatory aspects, but I'm not sure.
Given what we spoke about regarding keeping existing documentation and keeping that in peri-op doc, I don't want to confuse others because the internal workflow and the follow-up orders is all ambulatory. We'd have to change everyone's positions to an ambulatory position. You wouldn't be using SurgeonEd anymore. You'd be logging in a power chart. So there is a pretty big change. And don't think we want to go that direction.
Yeah. I guess that's the impression I'm getting too.
Yeah, because
Which
it's
is
a
great,
pretty
which is great. It's
large
okay
change.
too.
Yeah.
It is. Yeah. I guess we just wanted to confirm that as well.
So we wouldn't be able to set up like or establish follow-up order in Cerner?
I think it comes back to that kind of like first decision. There's a kind of the tree, right? There's the question about like the core location, which sounds like we can do, but within that new core location, are we maintaining, your existing kind of surgical scheduling workflow with the peri-op doc and that stuff we discussed versus moving into like more of an ambulatory workflow, which is I think what Jennifer's describing. So I think based on like the kind of first piece, it sounds like if we're keeping the surgical flows, then I don't think we would be necessarily able to like create all of those separate referral ambulatory orders and stuff, right, Jennifer?
That's right.
That is a good question though. Like I'm trying to think, are there any other clinics that like do surgical scheduling, but then also just utilize follow-up orders? So not like the referral order because there's a separate whole booking package process for that, but like the follow-up orders, Jennifer, like is that something we could still create for this new core location? Just like create like just a follow-up order for it?
It's not standard, but we have worked around some of the clinics, so I will have that as a takeaway to see if anyone...
I do know prevention clinic. They do they put a follow-up order into the internal request listing.
Right. Yeah. Because if that could work and you guys would want it to go to the same request list, right? Like you'd want it. Yeah. So yeah, maybe Jennifer, that could just be a takeaway. We can see if that's possible. Because it sounds like you guys only would want a follow-up order, right? You wouldn't need like another referral order or anything. It's just for those follow-up appointments.
Yeah, because that's easy to keep tracking and managing because right now everything on a spreadsheet, and as you can imagine how we're manual to keep tracking, keep information accurate.
Yeah, that's rough. We really would like to try and solve that for you
Yeah.
guys. The less spreadsheets, the better. And I'm almost certain there are areas that basically they use like surgical appointment types for the actual surgical procedures, and then they'll use like an ambulatory appointment type for a follow-up, which is linked to an order. But I can't honestly don't remember for sure. I can't name one off the top of my head.
That's exactly what I was going to ask you is like what would the because they have a surgery appointment type. So then you mentioned a follow-up order. I'm like, well, that would be under ambulatory. So it sounds like they'd be kind of split. They have surgical orders and they're also going to have an ambulatory workflow. Is that what you're thinking?
Exactly, just for the follow-up and just to see if like we could just utilize the request list they have for this new core location and just basically have like an ambulatory appointment type linked to that follow-up order. And that would almost be like an ambulatory workflow that would happen after they've had their surgical procedure, which would be using a surgical appointment type. But again, I don't know for sure if that's possible. So Jennifer, maybe that can just be a takeaway and you can let us know if that's something that is we're able to do.
Definitely.
Thank you so much, Jennifer. Okay, then I won't go into like other
Rose, sorry,
ambulatory
Vanessa,
stuff.
Rose has
Sorry.
her hand up.
Oh, okay, sure.
No, I got my question then.
Oh, good. Lingering hand. Never mind.
We still have a good time. I just wanted to go over, I guess, some message center pools, questions, and printers. I'm just gonna end my slideshow for a second. So actually, let's just talk about the printers really quick. So sorry, let me just pull up this. There's this screenshot that I had to put down. So right now I don't know if there's been a discussion already with Nikki establishing printers and where things would be printed. I would assume you guys would want your reg printer to be where the printer is at the reception area. Is that correct?
Ideally, the closer to the room, the better, because
okay,
we're always printing off lab recs and that for each.
This is registration.
Oh, registration. Then,
yeah,
that's
okay.
fine. Yeah.
So I'll keep the registration printer where the clerks will sit at the reception area. As for the requisitions, I had the same thought as you, Nicole. I was wondering if you guys would want it here in this area 151. It seems to be like this alcove workstation here. That is the closest one to you guys. Otherwise, there is one here as well down the hall. I'm just not sure which one you guys would prefer.
I'm thinking be the one down the hall there.
Oh, the one down the hall, right? Okay.
Yeah.
Because this one would be closed off. This is like the staff kind of hall. And then this is where patients would walk to some of these exam rooms, the corridors.
Yeah.
But yeah, so I'll pick this one then down here in this 168 area.
Okay.
Perfect. As for your label printer, I'm assuming it'll just be right beside the registration printer here. So we'll select that one. Do you guys utilize a narcotic printer?
No.
Okay, perfect. That answers it. Medical service we've established. Do you guys utilize single document scanning?
No.
Okay. For message center pools, these are currently some of the pool members for the provider group. Is this still the same? And I have Dr. Grannon as the team lead.
Susan Ackland is no longer here.
Okay. And then as for the admin group, I have this group here. Besides Susan, is there anyone else we could?
Going back up to the one above, so Jenna Antoniak, I don't know who that is.
Oh, okay.
And Human Tennessee.
It's a bit hard to see the names.
Oh, is it? Sorry. Let me see if I can. Is this
Yeah,
better?
like so Ackland, Antoniak, Hennessy, Sistak. I don't know who those. I mean, they're not here.
Okay. Okay, I can have a discussion with Dr. Grennan to see if he would want to add or remove any of these members.
Yeah.
As for admin, I have Claire down, but I'm assuming she's not here or no longer. Okay. Would you like to be the admin lead then, Nicole?
For now, I could say yes.
Okay. I'll note that for. Okay. This is just some of the lab stuff.
Hey,
For
Vanessa,
the
JP. Sorry, can we go back up to the
oh,
pools?
yeah.
We also have a point at this time to rename. I don't know if you guys want to keep SPH OPD ADC, but we can also change it to SPH anal dysplasia provider and then SPH anal dysplasia admin, or however you guys would like to change.
We probably could change it to that since we kind of want to be OPD after.
Mm-hmm.
Yeah. Display. I think it's anal. The clinic
Dysplasia.
core is this. Yeah. What's the core name? I'll keep the core name. Is that okay? Because I don't know if you can write. Can you? I mean, I don't know if there's a character limit with that, but okay. So I'll say provider, and then
And Vanessa, let's just check out how other core locations do, because I think that anal dis thing is like just the shorthand version of the core location name. I'm pretty sure it's actually fully spelled out like in the core location. So, but let's just see. I know there's like there's a model thing that ambulatory follows. So we'll just do whatever they usually
We do have the real estate, so I believe it's 45 characters. So if we want the full name, yeah, that works.
Let's do that.
Yes.
Thank you.
Awesome.
Perfect. Thank you. The lab stuff we'll fill out in a sec, but for future order requisition printing, it looks like you guys have it flexed for active orders for the MI orders. Is that correct?
And what is it for requisition printing?
So this is what you were talking about earlier. If you wanted some stuff printed, for some reason the current printer is to JRC right now.
Oh yeah, no. Currently, we do print to here in
Okay.
OPD.
So shall I just keep this printer on the bottom then for your requisitions? Or do you prefer to have it printed where the clerk is?
No, I think that one down the hall there is good.
Okay.
Yeah.
Okay, I'll just note that.
I think the medical imaging department have put this one as a bit of an unusual one to have this as flex to active order for medical imaging recs. So they usually recommend future orders for medical imaging recs. So if it's okay, would you say that we can change that, Nicole? They wouldn't be having the medical imaging right then.
No, they wouldn't. Yeah.
Okay. Okay, I'll note that. Good call out, Christy. I didn't know that. And then registration, it sounds like there's no labels printed specifically for this clinic. Is that going to be still the same? You guys don't want any labels printed actively?
We do usually have patient labels printed because we use them for our specimens.
Oh, okay. So for non-blood specimen, right?
Yes.
Okay, how many would you like then? We could just have it turned on. Would 2 be enough? 10? Okay. Oh. 10. Anything else out of this list that you would like?
No, I don't think so.
Okay.
We don't do any armbands here.
Yeah, so I think I'll just clarify with them to have that turned off with armband. Other than that, I don't think there's really anything else for me. Does anybody else have any questions or comments? I'll just open the chat right now. Okay. Well, thank you, everybody. We'll take away some of the stuff that we've talked about today, but in the meantime, if there's some other things that have come up, please let us know. Feel free to email myself. Please include Christy as well as Mike. So then we can follow up with that. I am off as of after today for a few weeks, unfortunately. So if you could just reach out to one of us on the clinical informatics team, I'll be able to just follow up with that once I'm back. Or they can help me follow up with it in the meantime.
Okay.
Okay. Well, thank you, everyone.
Sorry, Vanessa. I was just gonna say, you guys can include me, Jesse, just to cover for Vanessa while she's gone.
Okay.
Thanks.
Thank you.
Perfect. Thank you, everyone. Have a good
Thank
Friday.
you.
Thank you.
Have a great weekend.
Take
Thank
care.
you. Bye-bye.
Bye.